Thank you. I've been well introduced, and just to re-echo that I'm Jonathan Mayito, a PhD student with Thrive, and on the slide are my supervisors. My topic or focus on the PhD is detection of Mycobacteria tuberculosis in peripheral blood, pluripotent hematopoietic stem cells in latent tuberculosis infection. That's the outline. We define latent tuberculosis as persistence of viable Mycobacteria tuberculosis, however with immune control, and with no evidence of clinical or radiological disease. It's currently estimated that about 1.7 billion people in the world actually have latent tuberculosis, and it has been described as the seedbed for active tuberculosis and somehow slowing the control of tuberculosis in the world. Someone who is latently infected and without HIV has a 5 to 15% risk of progressing to active TB in 18 months to 2 years. However, if you're HIV infected, you have a 15% chance of progressing to active TB in 1 year. There are persisting dilemmas in the diagnosis and monitoring treatment for latent tuberculosis. And this has been because we use proxy methods to diagnose latent tuberculosis, and the detection of mycobacteria in latent tuberculosis infection has remained elusive. However, there is suggestion that stem cells might just be the answer because of certain inherent properties that they have. One, they reside in an immune-privileged environment. This is the bone marrow. And it means that if they gain access to the bone marrow, then it can safely hide there. Two, the bone marrow is a hypoxic environment. And hypoxia is one of the factors that is known to induce dormancy in organisms that live in such an environment. And Mycobacteria does that very well. Three, stem cells possess drug efflux pumps. It means that whichever drug we use, once there's infection in the stem cell, that microorganism will be protected from that drug. And four, the stem cells themselves are unable to clear any mycobacterial infection that gains access to them. And very importantly, we know that TB can reactivate in any part of the body. And we know that stem cells are responsible for repopulating any cell related to blood formation in the body, with their sister cells, the mesenchymal stem cells, that repopulate the other connective tissue cells. Key to this project is that we are able, much as stem cells are made and reside in the bone marrow, we are able to harvest bone marrow in peripheral circulation, and therefore they can be handy in diagnosing latent infections. There's some preliminary work that suggests that actually this could be a true hypothesis. Just because in 2013, actually was able to demonstrate that Mycobacteria tuberculosis infected and survived in stem cells in a dormant state. And Tonak et al. In 2017 also were able to demonstrate that stem cells harvested from interferon gamma positive patients actually harbored Mycobacteria, and those who are negative did not harbor any Mycobacteria in their stem cells. But these were very small studies, and much of the work was in vitro work. But very interesting that when this Mycobacteria in these stem cells was transferred to immune deficient mice, it was resuscitated and was able to cause disease or latent infection in those immunodeficient mice. As I highlighted earlier, that the problem is with us. The tuberculin skin test and the interferon gamma release acid test, they measure immune response, which only tells us that this person had prior contact with a TB antigen. But this person could have cleared the infection, but the immune response persists. So it's not that everybody that is positive on these cells will go on to get active tuberculosis. And as a result, these tests have very poor predictive value to who will develop active tuberculosis. And this has been a problem in trying to scale up treatment for latent infection. With these tests, you need to treat about 100 patients to prevent just one case. This is not feasible to our resource-limited settings. 2, there's no clinical, radiological, or laboratory parameter to monitor response to treatment. Once you've given treatment, you hope that the person is cured. And so therefore, we're not able to know who has not cleared, who has resistant infection that has not cleared and probably needs other form of treatment. In this project, we shall therefore try to evaluate a method that can help us actually look for evidence of mycobacteria presence in latent tuberculosis. And through these 3 objectives, the first one is to determine whether MTB is detected in these stem cells of contacts of TB patients, because the contacts are the ones that are more likely to have latent infection. And then 2, we want to determine if the current treatment that is used, isoniazid, has any effect on the TB that is detected in these in the stem cells. And then 3, we want to determine the prevalence and determinants of nuclear positivity in these contacts. This is the general flow of the study. We will approach the index TB patients and request them to access their contacts, who we invite to consent for the study. And then we subject them to the study inclusion criteria and exclusion, and then we consent them for the study. So we divide the groups mainly between HIV positives and HIV negatives. And for the HIV negatives, once we've done the study procedures, that will be the end of their study. However, for the HIV positives, they'll have a prospective arm. Once we've done the first, the baseline study procedures, then they'll be Satigone and isoniazid for 6 months, and then we shall follow them up after 6 months and repeat the same study procedures. The key procedures in this study will be to get peripheral blood from these patients, isolate the mononuclear cells, sort out the stem cells, extract their DNA, and then run PCR. All these methods have been optimized and are now well set to be applied on the main study, And this was after a rigorous process of about 3 months at the Queen Mary, University of London, and Cambridge University. It has been a slow process, but finally the study is off to speed. For the first objective, I need about 120 participants, and so far 18 have been enrolled. Enrollment has just barely a month now. And the second objective, 60 patients, 3 have been recruited. And the third objective, 288 patients, and 18 have been recruited. And the laboratory work has also started. It is up to the stem cell isolation, and then they are stored for further processing. This work, for the next 6 months, we're going to continue the recruitment and follow-up of patients. And if our projections go right, we hope to complete the follow-up by December. If it lays, maybe it spills off to January, and if very late, maybe to February. But alongside this, I'll be doing also the thesis writing, and the data from objective 3, I hope to get it much faster than the other objectives, and I'll start to prepare the manuscript, analyze it, and prepare the manuscript for that. We already published a review on this work entitled Anatomic and Cellular Niches for Mycobacteria during Latent Infections. And this was published last year in October in the Journal of Infectious Diseases. The other potential publication that will arise from this work, one is stem cells, depending on if we get positive results. Stem cells can be targeted for diagnosis of latent tuberculosis. Then 2, detection of MTB stem cells can also effectively be used to monitor treatment of latent tuberculosis. And then the determinants and prevalence of gram positivity in those who are negative of symptoms. Other than the PhD work, been involved in some engagement activities. At the Infectious Diseases Institute, I teach students from Makerere, from other universities around, and we discuss clinical as well as research work. And then I adopted a school called Midland in Kawempe that I've had several contacts with, and discussing career directed topics with the students. In these pictures that you saw, these were close to 200 students, and we're discussing that how would they survive beyond the career that they are studying for. And it was very, very interesting discussion, and these students had all sorts of ideas about what they could do if their career does not succeed. Other than the group discussions, I normally sit and then do one-to-one career guidance to the students. Thank you very much.